All right, good afternoon, everybody, and welcome to Health Research Live. My name is Marco Staffney. We're going to just hang out for a few minutes here, another two as more folks enter into our Zoom conversation today. If you're here for Health Research Live Telehealth, then you are in the right place. I will get started in just a few moments, and I will just welcome you in. We will be using the chat feature in today's program, so if you've never used the chat feature, now might be a good time to try that out. It's that little speech bubble at the bottom of your screen if you're on a desktop, and to utilize the chat feature on an iPad or an iPhone, you can just click the three little dots that's somewhere on your screen and then look for the term chat. We'll be using that to ask questions at the end of our program today, so if you're able to just try that out, you can always just say hello to us right now in the chat. Where are you beaming in from? And say hi, who you are, and what's your favorite exhibition at the Montshire? It's always a good one. We're really excited to have everybody joining on right now. I do sound a little bit like a broken record for this first 2 minutes, where I just remind people that we're going to be utilizing the chat feature at the bottom of the screen on your little control panel there if you're using a desktop, but also three little dots if you're using an iDevice like an iPad or an iPhone or an Android. So if you're here for Health Research Live, you're in the right place. We're going to get started in about 1 minute. Just giving everybody a little bit warning why some more people are beaming in. We're really excited to have a good group of folks joining in and pre-registered, and some amazing speakers today. Just give me a moment. I'm going to switch my screen here. Okay. Hi, everybody, and welcome to Health Research Live. My name is Marco Staffney. I'm the Executive Director of the Montshire Museum of Science, and we are so happy to have you here today for our program about telehealth. Our program is produced and organized by the Montshire Museum of Science, the Public Health Council of the Upper Valley, the Dartmouth-Hitchcock-Norris-Cotton Cancer Center, and Dartmouth-Hitchcock Population Health. Telehealth has rapidly expanded in the past year due to the COVID-19 pandemic. Today, Kevin Curtis, the Medical Director of Connected Care and the Center of Telehealth at Dartmouth-Hitchcock Health, and David Park, a doctor at the White River Family Practice, will discuss what advances have been made and how does this affect public health. Also, what does this mean for how people visit with healthcare providers long after the pandemic? So, how does this work today? Each presenter will talk for about 15 minutes. Then we'll be breaking up into virtual Zoom rooms so that you can have smaller group discussions about what you've heard for about 10 minutes. Then we'll come back for a broader Q&A that will host the chat feature. And with that, Kevin, I'm going to hand it over to you. I'm going to stop sharing my screen and allow you to share your screen.
Great. Thanks very much, Marcos. Great to be with all of you. And I'll share my screen. So again, great to be here with all of you this afternoon. I thought what I'd talk about first is what you already know about our region, but remind you and then talk about some of the challenges that poses in healthcare, and then segue into how that resulted in us forming our Connected Care and Center for Telehealth. Talk a little bit about our response to COVID-19 so far, and then since some of the focus here is on research, highlight two projects that we're doing right now in Connected Care. So this is a population density map, and you can see New England here. And if you focus on northern New England, meaning Vermont, New Hampshire, and Maine, you can see, as you already know, that most of it is rural, but it always strikes me as I see this, how much is even classified as isolated. And then if you compare that, of course, to our southern New England neighbors, Massachusetts, Connecticut, and Rhode Island, you can see a markedly different population density there. At the same time, in those same three northern New England states, each has one academic medical center, as opposed to a whole bunch in Massachusetts, particularly Boston, and in Connecticut. And I point this out not at all to say that's where the great care takes place, because actually many weeks I think it's a lot the opposite, because I do teleemergency with a lot of small emergency departments in the region, and I'm constantly amazed by how they take care of the same patients I see at the medical center with many fewer resources. But I pointed out just to say that at academic medical centers, that's where there's a disproportionate number of specialists typically. And then the result, as you know or would expect, is it can be long distances to care, particularly specialty care. The arrow here is if you live in Colebrook, New Hampshire, where Upper Connecticut Valley Hospital, UCVH is, which is a outstanding critical access hospital. It might be 2.5 hours in the summer to get to a specialty appointment at the medical center, or 4.5 hours or never in the winter, depending on if it's tomorrow when there's a storm coming. So all of that, the rurality, including isolated regions, and the disproportionate number of specialists at the medical centers and the distance led in 2012 to us forming the Center for Telehealth. And the mission continues to be, how do we help deliver outstanding care to the region independent of patient location? And we have a strong focus on rural healthcare and a secondary goal of how do we keep care local in local communities whenever possible. Right now we have 7 telehealth service lines or service categories, and I'll only mention these briefly just based on time, but we have teleemergency, where a doc and a nurse from our hub work with emergency departments in New Hampshire, Vermont, and Maine. We have teleneurology, which includes stroke, and our neurologist can be available 24/7 to help with stroke or neurologic emergencies. We have tele-ICU, not only at our own medical center, but in northern Vermont, southern Vermont, northern New Hampshire, and southern New Hampshire. ICN is our neonatal emergency service for either anticipated or unanticipated challenges with deliveries. Outpatient virtual visits that many of you may have participated in is, unlike those emergency services, that's our scheduled visit with primary care or specialty provider. We have telepharmacy at 23 hospitals and telepsychiatry, in this case, for emergencies for people presenting to emergency departments with mental health crises. This is just a map summarizing at least the facilities where we work, in a lot in New Hampshire and Vermont, and a little bit in New York, Maine, and Massachusetts. I can't put people's homes on here because we're up to about 200,000 of those, so I don't think we'd have room on the map. But and then before kind of getting into the research and a little more, just to say that the way we approach telehealth in all situations, including if a group comes to us or a hospital or a community and says, how about some of the telehealth stuff? We really focus on the care first and the technology last, to say, let's not do it just because we can or because it's the new shiny thing. Let's figure out how to bring it in a way that actually improves health or outcomes. So along those lines, just quickly, we've done a little over 2,000 tele-emergency encounters, and we're seeing more expedited care and improved outcomes for some of the most critically ill and injured. We're up to almost 6,000 tele-ICU admissions, and we're seeing, again, people staying locally and shorter time in the ICU and shorter time in the hospital overall. We've done 4,000 tele-neurology consults, and we're seeing people with stroke symptoms be able to go to whatever their local hospital is and get the same care as if they presented to a stroke specialty center. We're over 2 million telepharmacy order, and not only are we helping smaller hospitals with efficiency, but are helping to avoid medication errors. We'll talk in a little bit about COVID and outpatient virtual visits, and we're a little over 100,000 of those. We've done about 600 emergency telepsychiatry consults, and people are able to spend less time in the emergency department as a result. And in our neonatal care, which is one of our newer services, it used to be that almost all of the babies that had tele-ICN consults before telehealth, had ICN consults before telehealth, would need to be transferred to the medical center, even if just overnight. And now we're seeing that 3/4 of the babies can stay local with their families. As far as our response to COVID-19, obviously there's a bunch here, but I'll just highlight a couple things. If we look under the heading of emergency and inpatient here, one of the things we did in both locations. A lot, as you would expect, of what we did was an effort to limit exposure for patients and staff and to preserve PPE. So in the emergent and inpatient setting, we deployed a lot of tablets and some telehealth carts to locations such that patients in the rooms, either by themselves or with a nurse, could communicate with their doctors, consultants elsewhere in the hospital, at home, or with other family members when the visitor policy is so strict. So we can limit the number of people in the room and provide that communication wherever the others may be. And we saw, so far we've seen about 1,000 uses of that in the emergency department and about 300 on the inpatient units. From the critical care or ICU standpoint, separate from our normal tele-ICU service, we sent about 18 tele-ICU carts around the region to different smaller hospitals so they can have an on-demand emergency consult with our critical care doctors, particularly for people that have COVID-19. And in the pharmacy space, we were the telepharmacy service for MGH's field hospital that they stood up in the first wave of the pandemic. Looking a little bit more at outpatient. So this is a graph of the average daily outpatient telehealth volumes in our health system at various time points. And for this, it's video plus telephone telehealth. And prior to the pandemic, outpatient visits was actually our least busy service. You saw thousands of some of those services. If you look to the left of this, January 1st to March 17th, we were only doing about 8 outpatient virtual visits a day. The pandemic hit, the health system closed, and like most health systems, we saw this exponential rise in outpatient virtual visits, going from 8 a day to, in April, we were doing about 2,100 a day. And then it tapered back down to a new plateau of about 700 to 750, so less than the peak, but much, much more than prior to the pandemic. That leads us to a couple projects, research projects I'll talk about. So this is a research endeavor funded by the NIH that we're working on, their National Cancer Institute, and it is focused on what has gone on oncology care in response to the pandemic with telehealth. What I'm showing you here is the percent of outpatient visits being done by telehealth each week. So, an outpatient visit can be in person or it can be by telehealth. And so we walk along here, not much is being done, and then the hospital closes, and many of the services go to almost 100% telehealth initially with the hospital closed, and then many taper off. So now we have a little bit outliers here. So psychiatry is shown here. They continue to do 85 to 90% of all their visits by telehealth. And then you see a couple that are lower here. This is orthopedics, peaked not as high and has stayed quite low. And we tend to see the more procedural the specialty is, the less percent telehealth they're doing. And oncology, which is we're focusing on, is somewhere between these two and orthopedics, but relatively low percentage of telehealth. This doesn't mean they're doing something wrong. This means we're trying to really understand providers, patients, and the service to understand why is it 10 or 12% telehealth. We're also looking of that telehealth, how much is video and how much is phone. So this is the percent of outpatient visits delivered by video. Prior to the pandemic and closure, even though very little was being done, it was almost all video. Hospital closure and academic medical center overall initially is doing most phone. That's what people are comfortable with. And as everyone becomes more comfortable with video, we now are doing about 2/3 of our telehealth visits by video. Oncology, in contrast, went down to doing essentially all phone only and is only increased to about 10 or 12%. So again, we're doing a lot of work now to understand that. And these things are not, they hadn't been previously reported. And the last, the other research project I'll talk about is one of the things that happened is, as I showed you, everyone started doing a whole bunch of telehealth. It hit a peak and then it started to hit a plateau. And many specialties and the providers were coming to me and saying, what's the right amount of telehealth going forward in my particular specialty? And we became aware of the fact that nobody had answered that question before. So we designed a 10-question survey and sent it out to our staff physicians and associate providers who see patients in the outpatient setting, and said a bunch of questions about where they work, what specialty, et cetera, but really trying to get to this question. What percent of your outpatient visits do you feel could be adequately delivered specifically by video? We did, again, anticipate, like we talked about ortho, that it may be more in less procedural specialties than in more procedural specialties. These typically things that have surgery in their name. What we saw was in the less procedural specialties that the most common response was people thinking that 21 to 50% of their outpatient visits going forward beyond the pandemic could be delivered by telehealth. And then secondary would be either over 50% or 6 to 20%. So quite a sizable amount. And indeed, although more procedural specialties did say that it was probably fewer, still the number one response was 6 to 20%. So not a trivial amount, and the second being 21 to 50%. So on the provider side, feeling that after this forced exposure to telehealth, really this is something that could stay for the future. So I'll stop there. I'm really looking forward to the subsequent Q&A, and I'll hand it over to Dr. Park, and I will stop sharing.
All right, thank you for inviting me today. I want to give you a little background. I'm one of 5 partners in a private practice, private family practice based in White River Junction, Vermont. Depending on what your definition of how we define a current patient, we take care of anywhere from 12 to 14,000 patients in the Upper Valley area. As you can imagine, you know, because it happened what feels like both a long time ago and very recently, when the pandemic hit, we were scrambling. You know, we, of course, our biggest concern was the health of our colleagues, the health of our staff, and then, of course, making payroll. You know, when everything hit and shut down, we were, I think telehealth was kind of more of an idea than a reality. As one of Kevin's slides pointed out, we had thought about the idea of telehealth as being a great, you know, possibility at some point in the future, but there's just such a huge barrier in trying to initiate any kind of working that into our normal day, because there wasn't the reimbursement necessary for us to justify doing it. So when the pandemic hit, it was a natural situation where we were forced into doing it, and thankfully the insurance companies agreed to, you know, cover telehealth visits the same way they would cover face-to-face visits, and then I think what also really helped us quite a bit was Health and Human Services waiving their requirements for HIPAA compliance. So I think one of the big concerns was that there were only a few platforms when the pandemic hit which were actually HIPAA compliant. HIPAA is the healthcare, it's basically the Privacy Act, and I forget what HIPAA exactly stands for, but pretty quickly when we were thinking about what we had to do, HHS decided to waive HIPAA requirements, or actually I think it was more technically declining to prosecute if we did not use a HIPAA compliant platform. So that enabled us right away to use FaceTime, which is one of the most common things we use, Skype, which was probably a quarter to a fifth of our visits, and then just telephone for people who who just didn't have, who had connection limitations or did not have the technology available to engage in a telehealth visit. And within the first like month and a half, we were doing a lot of telehealth. I don't have the exact percentages, but there were days where I work 4 days a week, and 2 to 3 of those days I'd be at home on my computer conducting telehealth visits. And thankfully our staff pivoted very quickly, and were able to get people to figure out how people could connect with us. And again, having those 3 options, FaceTime, Skype, and telephone, if all else failed, really kind of covered everyone. Also, what was important was, at the time, was the willingness of our patients to make this change. I think, if we all think back to March, we had images of northern Italy, and then stateside New York City filling up, and we didn't kind of know what we were dealing with. So it was very easy to convince people and ourselves that this was the best way to conduct healthcare, just to protect ourselves and protect our patients. And it worked. It worked really well. Patients were very willing to do it. We were willing to do it. I think one thing that took a big hit for us, though, was the culture of our office. One thing that we really pride ourselves on in our office at White River Family Practice is that we have this very close-knit group of providers, ancillary staff, that if you come to our office, where I and my partners and our associate providers work, it's a gigantic room with no dividers. We all have desks in there, and we all work in there, and we sort of cover for each other, or we ask questions of each other, and we kind of think of ourselves as a little bit of a collective mind to help each other. And once the pandemic hit, we had to start spacing ourselves. We had and expanding out into an office space next to our office that was unused, and we now are kind of taking over 2 suites in our building. And whereas I had always been shoulder to shoulder with my partners, now I'm in an empty room by myself on a desk. And so, though telehealth was really good for kind of keeping our business going, our morale did suffer quite a bit, because just having those by the water fountain talks, or just kind of pivoting to my left and asking Dr. Julie Davis, what do you think of this patient of mine who blah 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 blah? It made it a lot harder, but we were able to keep going, which was, of course, the most important thing, both for our patients and for our business. Probably, I think around the same time that Kevin's slide showed, that around May or June, we decided to sort of, once we kind of had an idea of how low the numbers were in our area, we kind of followed DHMC's outpatient clinic lead in kind of shifting away from telehealth and back to face-to-face visits. And a lot of that was actually fueled by patients. I think by that time, patients were having a little bit of, or just a little bit less willing to meet by telehealth. They really wanted to have the face-to-face visits for certain things, which were certainly justified. And I think we as practitioners also felt very comfortable, or more comfortable at that time, shifting to a large proportion of our visits being live and in person. And so in the late spring and through the summer, we shifted back to live in-person visits. And I think I would say around 80% through the summer and into the fall, about 75 to 80% of our visits went back to live and in person, and we sort of integrated telehealth when necessary. And I think what has persisted are, as far as telehealth visits now, it's mostly people who are where it's really difficult for them to come here because of, for whatever reason, whether it's transportation or because of physical limitations. Oftentimes we will, if we're seeing a patient for a psychiatric reason, we're starting them perhaps on a medication, then we will oftentimes have the follow-up be on telehealth because there's no real need to pursue a face-to-face visit. And I think moving forward, we definitely feel like telehealth is here to stay for us. It really serves a real need for a lot of our patients who prefer it. And it still feels like right now, especially with numbers kind of going up here, we're using it quite a bit now as an initial visit for our patients who call with like a cough or a cold, so that we don't have them come in case they are carrying COVID. So we're kind of using it as an initial step to evaluate somebody, though we're still having people come in where if we're worried about whether their cough and breathing problems are because of asthma or because of something like COVID, or if we need to get a pulse ox, find out what their oxygen saturations are. But we're pretty excited about continuing this, and we've now contracted with Zoom because we're trying to prepare for perhaps when the waiving of HIPAA ends. And so we now have a contract with Zoom because Zoom is one of the telehealth platforms that is considered HIPAA compliant, and we've been integrating that more. And so I'd say like maybe a third to half of our current telehealth visits are through Zoom. The remaining ones are through FaceTime. FaceTime is a small portion that are telephone. We've pretty much dropped Skype because we found it to be pretty cumbersome and difficult to use. And I think as far as the culture of our practice, we are making efforts to kind of reach out to each other and check in with each other. I find myself wearing my mask and going around to the different departments and just hanging out between patients, or at the end of the day just to catch up with people. It's still not the same, but we look forward to the time when we can all be vaccinated and can move back into our large collective office and kind of have things back the way they used to be, as most of us feel. So but we do feel telehealth will be a big part of what we will do moving forward. And I think we're thankful in some ways that COVID has forced us into this and forced us to adapt, and really enforced kind of our patients to accept it as a possibility. And I think it's changed a lot of our patients' minds as to what telehealth can be. So, because you have to have buy-in on both sides. But I think moving forward, I think some of my biggest concerns, and I don't know what the answers to this would be, but one of my biggest concerns would be that telehealth is really important for some people, but I think it is harder for people who don't have means to connect through telehealth, because it does require some knowledge of technology. It requires a certain baseline of a device, of a technological device to be there. It requires the means to have a connection from home that can stream video in a way that is actually helpful. So I do worry about what the implications are for healthcare equity in the future. And I think that's going to be a big problem moving forward, or something that we need to figure out. So that's where we are right now. Thank you.
Thanks so much, David and Kevin. Those were really great presentations. And David, thanks so much for bringing up all of the different types of technology that are utilized for telehealth and the different platforms. It's always a very big question. I've had a couple of questions come in the side. We'll address some of them in the Q&A after we do some breakout rooms. We have enough folks to do a number of breakout rooms. So what's going to happen next is that we're going to break out into small groups, and then you can discuss with each other. When you break out into your small room, we're going to ask that you unmute yourself or show your videos so that you can talk with other people. And then we'll only be in those breakout rooms for about 9 minutes. And then you'll get a 1-minute reminder that says we're about to go back into the larger room where we'll all join together. It's always helpful if one of you would like to take some notes or put down some questions or some comments or feedback that has come up from your small group. Laura in the chat right now has put in 3 different questions that we'd like you to think about as you get into your room. So after you do a quick introduction of yourself, just discuss what are the opportunities of telehealth? What are the challenges of telehealth? And what questions might you have for the presenters? We'll be doing this for about 9 minutes. We'll come back in. None of the small breakout conversations are being recorded. We are joined today by CATV, who's our recording partner in this so that we can put this up onto public access into YouTube. But the small group conversations will not be recorded. So without further ado, I'm going to open all the rooms. You might get a little button that says join room now, or you might just get dumped right into that room. All right, folks, as we're coming back online, might want to change this to gallery view just so you can see everybody who's back on. We're a smaller group, or should be. Actually, I'm going to close all the rooms in just a moment.
Can I raise another issue while we're waiting? I'm just curious how the care providers, I know they did this because they had to, but do they like doing it? That's something I'd be interested in.
That is a great question. Maybe we'll lead off. I think everybody who's back or who is going to join us back is now back in the main chat Zoom. So do the healthcare providers like it? And I guess from both perspectives, we have David, who is a healthcare provider who's automatically doing this. And we also have someone who's looking at a system, if that's even a question within the research, what is the actual temperament of people actually doing this? So David, maybe we'll start with you on that answer or that commentary.
With me?
Yeah, go for it.
Okay, so yeah, so I look at it 2 ways. On one hand, I think it's great. I mean, I think it's for some of my patients where it has been difficult, or it is difficult for them to get to our office. I think it's fantastic. I think it's really powerful if we can kind of leverage what it can offer us for these patients, especially who have transportation difficulties. I can say from a personal standpoint, the actual visits, I don't mind them because I recognize how helpful it can be for our patients and for us just as far as filling our schedules. I have to say, though, that it's having never actually sat at a desk staring at a screen for 3 hours at a time, it's really painful. I think in March and April when I would have entire days, with a full schedule of 12 to 15 telehealth visits, I had to force myself to get up and walk around if I had extra time, because I did not realize how just in the run of the day, going from one room to the other room, standing up to wash my hands, walking around the exam table while I'm examining the patient, just moving the body around even in those small ways really is good for the body. So I think it's if I can take some Advil, then I like it. That's how I would put it.
The majority of us on this call can probably commiserate with your experience of sitting too much in front of a computer. And there's also a lot to be said that there is a difference between in-person temperament, phone temperament, and video temperament, and interactions that happen on all 3 with medical care providers. Kevin, any research being done from a system-wide perspective as to whether or not physicians or medical care providers are enjoying this, or a scale of attitude?
Yeah, soft research, meaning a lot of questions and surveys. And what I would say we've learned is there has been a big shift in the bell curve towards greater appeal and favorability, meaning that there are people who currently really look forward to their telehealth day or telehealth half day as very exciting, and they love it. There's some people who aren't crazy about it, and a ton in between. But that was a big shift between, if you remember, we were only doing 8 visits a day in the outpatient setting. that was because most providers didn't see a need and didn't, as they imagined it, but didn't do it. This doesn't sound like medicine. So we have shifted the whole curve towards much more favorable opinion, but it is indeed a bell curve of loving it to guess I got to do it. And even among the guess I got to do it, everyone I've ever talked to said, if this is what I need to do to get to my patients, and so that we can meet and do what we need to do, then let's do it. If it is an option between this and in person and their equivalent, then that's going to vary tremendously by provider.
So there's a couple of questions that are happening in the chat right now on two different strands. One is a little bit about equipment and things that a person could have in their home to make telehealth a little more accurate. So is there, or have there been recommendations by either your particular practice, David, or system-wide, Kevin, for different equipment, different types of equipment to be in the home, such as a thermometer, a blood pressure cuff, a pulse oximeter, and then maybe, is there a potential for insurance reimbursements or grants to provide homes with this equipment to make the telehealth visit a little more, accurate or for the medical care provider?
Go ahead, David.
Okay, yeah. So yes, we've been talking about how we can kind of streamline things, especially if we can anticipate visits where people will need, where we want to check a blood pressure or check a pulse ox. And we're actually considering, we haven't done this yet, but we're considering getting blood pressure cuffs to give to people before their visits so they can record their pressures and we can have that information at the telehealth visit. We also have purchased a bunch of pulse ox monitors that we can give to patients who, for example, are, for any of our patients who are COVID positive and are stable and at home, for them to monitor their own pulse ox. But we haven't sort of rolled that out quite yet. I think a lot of our blood pressure patients do have their own monitors, so that does help. But we do want to have a supply of some to lend to patients of ours if they need it, because that kind of data is really still very important and an integral part of their care.
Yeah, I would say first, prior to pandemic or a lot of telehealth, there's a fair number of folks that are seen through the medical center or elsewhere that have scales, blood pressure cuffs, thermometers, et cetera, to help with their care. And I would say they are very poorly reimbursed by payers. So whether that becomes a video visit or whether you're just, it's important for you to monitor your blood pressure, your weight, et cetera, that has traditionally been poorly reimbursed. I would say taking it to the next level of telehealth. So there certainly are things that are out there and fairly good, such as digital stethoscopes that either a local clinician can help use or the person themselves can use. And those are, for most people, not at a good price point at all, nor are they yet reimbursed. So the hope is, as payers and others see the value, the overall value of care, not so much the cost of the individual device, that will change. But right now, the technology lags, the reimbursement lags the technology.
Another question that we've had has to do, and I know there are a lot of medical related people on the phone call right now, about staff morale and constituents. Are there any technology tools that are helping right now with folks creating communities of practice or talking about the type of morale that is happening in medical care facilities right now? David, I don't know if you're meeting with a network of other doctors, or Kevin, if that is something that's been thought about in terms of HR. I know for the first time from the nonprofit community, we're starting to see types of morale in terms of pandemic burnout. And so we're seeing HR things come through, at least in the Upper Valley, about all right, let's discuss how we actually maintain this now that we have sort of a 6 to 8 month to 12 month trajectory of where we're going with the pandemic. Thoughts?
Yeah, I think for us, I mean, something like, some kind of a network to be able to talk to other providers would be great. We've sort of been, it's hard not to just kind of focus on us and what we have to do. There have been some, because of the pandemic, and really expressly because of the pandemic, two of our associate providers are leaving next month. So we've had to sort of scramble and figure out and replace them, which has been really difficult. I know that, when, we've been having a lot more meetings as partners, meetings as a practice since the pandemic started, just to try to head off problems and make changes as needed. And a lot of times we will, I will email someone that I know who works in a particular department at the Mount Ascutney Hospital, or one of my partners will contact somebody, in a department at DHMC. So we are, we're trying to maintain connections that way. But yeah, I think we're right now, we're just trying to keep our head above the water, above waters right now. Especially with the personnel kind of changes that our practice is going through.
Yeah, I would say it certainly is a great area of focus for the health system and the hospital by a lot of different approaches. And, some of them, particularly, I think early on, they may be focused a lot on mission-driven energy, which at the early phases of the pandemic, so there's both mission-driven focus, there's support focuses, and there's relational focuses. And I think in a lot of it, the realistic goal is how do we keep ourselves in a pretty good place, understanding that it's not likely that we will be as strong as a team or as strong as we were before until we recover, but how do we keep it going pretty well, and even including things like we will try to intentionally schedule days at the hospital with our team and days not at the hospital with our team if possible, just to try to resemble the old world that David was describing, where we do actually, even with social distancing, mask and 6 feet apart, we at least can collaborate with others. And I think I'm feeling a move now to the last long leg being hope and future focused, which we weren't sure that when that would be, even if it's distance, even whatever we're talking about, even if it's the summer that will start to feel a lot different with vaccination. We have, I don't think I'm speaking out of turn and telling anyone what they don't know. We're still in the middle of the dark tunnel, and it's gonna, but we can see the light now. So I think it went from mission to stabilization to hope coming focus. That's how I am kind of seeing it and feeling it.
I like how you put that. And I think that one of the things that has kind of been a drag on our morale just this past week was that we normally have a Christmas party, like we take an extra long lunch break, the two Tuesdays before Christmas, and we have a Yankee Swap with our staff, which is always a huge highlight of the year. And what we've promised is that we're going to have a Yankee Swap sometime in the summer. Even though it doesn't necessarily have to be tied to the holidays, but we're gonna just push it off to when we figure there'll be a time to do it, and we're gonna set a time to look forward to, because I do feel like there is a hint of a light at the end of the tunnel.
All right, well, we just have a few moments left, and one of the alternative questions that came up was just about family members being able to attend and be on calls for telehealth calls. Have you had experiences with seeing an increase in family members attending medical telehealth experiences, I guess, from either of you?
For sure, yes. I think it's made, and I don't know if it's necessarily telehealth or if it's just what's going on right now with so many people being home, but when I have child visits, often both parents are there, when often it's just one parent bringing the child in because they're both at home. And then, of course, then you've got 3 other kids yelling and running around, so it can be a little bit of a challenge. But yes, I think it has offered, at least in that case, people to be there and to be present for the visits, which is great.
Yeah, I think like most things, there's certainly that's happening more. And I think there's two sides of it. There's many situations it's very helpful to have a glimpse into the home environment. I think that can be useful and overall better understanding the care that would be helpful as opposed to a sterile examination room at a facility. I think sometimes families have found challenges with anonymity that they appreciated or when coming in person. So we're seeing a lot more of it. And I think like many things, I'm seeing both sides of the advantages and disadvantages.
Great, thank you. Well, folks, we are just out of time now for today's program. We do always like to survey folks for this program to see if how we might be doing better. So I put a survey link in the chat box right there. It's very quick, very short, just to see what we might like to do more into the future with Health Research Live and how this program went today. So thanks for filling that out if you get a chance to do that. I do want to thank David and Kevin so much for their time and for their expertise and for their willingness to share this information. As I mentioned, our partner CATV will be posting this, and we'll have it either on the Montshire's YouTube site or CATV's YouTube site. So if you're curious about finding this information, usually a week and a half in terms of turning this around. We appreciate everybody being here for Health Research Live. This concludes our season, and we'll have some more information about future talks either from the Montshire or from Health Research Live out into the new year. So with that, I just want to thank everybody for participating today, for all of your voices, and I hope that you have a wonderful new year and that you can clearly see the small hint of the glimmer of the light at the end of the long dark tunnel that we mentioned today. So with that, thank you so much from the Montshire, Marco Staffney. Again, thank you, David. Thank you, Kevin. Thank you, Health Research Live team. And we'll see you out in the new year. Have a good day, everybody.